Good evening and thank you for joining us on Y254 News. My name is Patricia Muriuki. Tonight we're going to be talking about kidney disease, and with me in studio is Dr. S Murthy, a consultant nephrologist at Medihill Group of Hospitals in Eldoret. He has over 20 years of experience in medicine and nephrology with an interest in the field of dialysis and kidney transplantation. He has recently relocated in Kenya and is going to be helping us to understand how do we manage kidney disease, treatment, to look at signs and symptoms, and we are going to cover this during the 30 minutes that we have. You can be part of this conversation by sharing your comments and views in the number 22162. In case you also have questions that you would like to know from the doctor, you can also use the same SMS line to ask your questions. You can also tweet us at Y254 channel, hashtag Y254 News. Thank you very much, Dr. Murthy. Your name is quite a challenge for me, but I'm going to make sure that I'm going to deal with it. So thank you for really finding time to share your knowledge on kidney disease with us tonight. And my first question would be, for how long have you practiced and specialized on kidney disease?
Only kidney disease, more than a decade.
20 years.
More than a decade, only kidney disease.
Oh, kidney disease, 10
only
years.
Only kidney disease.
Okay.
More than that, more than a decade.
So kindly talk to our viewers and explain to us, what is kidney disease?
To put it in simple and put it in common man terms, see, the common idea all over the world for common people to think, for example, for any disease, the first symptoms are usually simple pain. Like if it is a headache, there is natural tendency it may be brain tumor, but it is not true. Similarly, if there is a chest pain, people are afraid it may be a heart attack, but it's not always true. So simply, say in kidney disease also, people think you have a back pain, and I get people running to me thinking it's kidney failure. No, it's not like that. So, kidney diseases, they, like any other organ, they tend to have symptoms depending on the disease. Depending on the disease that it produces. And particularly when it comes to kidney, heart and brain, or for that matter any organ of the body, what we call as lifestyle diseases are the main problems. Be it for the heart, be it for the brain, be it for the kidney, and eyes, legs. Lifestyle diseases, you know, they are all overweight, diabetes, blood pressure, high blood pressure, smoking, unnecessary medications. So these all affect all the organ systems. So kidney, when it comes to focus, the problem with kidney is people tend to think that the symptom may not be related to the kidney. Like the symptoms of kidney will not, as I was telling, it is not always specific like a chest pain or a head pain. Like a back pain or a loin pain is not always a kidney failure. It may be a stone at the most. Maybe, that too maybe. So the earliest thing to pick up is not the kidney disease, or for that matter, why kidney disease? You got to prevent heart disease also. You got to prevent bone disease also. So you have to pick up the basic causes of our lifestyle problems. Then the other, all the diseases, they come into control. They come into grip.
Okay. Now, talking of kidney disease, we know that there are signs and symptoms for every disease, and if my director can play for me some graphics of the signs and symptoms that we have on kidney disease, we can see that we have something like vomiting, we have poor appetite, we have poor sleep or lack of sleep, and a reduced amount of urine, swelling on your legs. When you look at these symptoms, are symptoms that probably are shared by other diseases. When you have malaria, you have loss of appetite. When you have malaria, you can still have vomiting. So how does a patient, or how now does a doctor really know that this could be kidney disease and not any other disease, to avoid maybe wrong diagnosis?
The problem is particularly when it comes to kidney disease, the symptoms that you have told are non-specific, like nausea, vomiting, and lack of energy, listlessness, lack of appetite, and so these could easily be mistaken for another non-specific complaints, and maybe he will be going around his GP or a family doctor, and it may take some time for him, for the general doctor to point out that this could be a kidney disease, unless there is swelling of the body and a lack of urine. So these are signs of advanced kidney disease. So in any system disease in medicine, the early symptoms seem to be very non-specific and may not be there. For example, high blood pressure. 140/90 is high blood pressure for diagnosis, but you will not have symptoms unless your family doctor is very alert and tries to pick it up. Like 126 for fasting blood glucose is diabetes, but you will not have symptoms unless they have crossed around 150, 200. So then, then you have symptoms. So early kidney disease, particularly medical diseases due to lifestyle problems, diabetes and hypertension, or immunological diseases or genetic diseases, they tend to be actually no symptoms in the early stage. Though if we say if there are 5 stages for a chronic disease in kidney, what we call as in technical terms, the earlier 3 stages are easily missed unless the treating family doctor is very alert to the possibility that a given complaint in a given patient is because of the lifestyle diseases which could result in a kidney problem.
So now speaking about the signs and symptoms, now what are the causes? We know we have risk factors whereby probably someone who has diabetes, which we know could be generic, stands a high risk of probably getting kidney disease. Now considering all these things, what are some of the high causes of kidney disease?
See, though we say that lifestyle diseases are causing kidney problems, heart problems, and brain problems, so to say lack of blood supply to many organs, because along with this high cholesterol is added, high uric acid is added. So and then medication side effects, multiple medication, the whole thing becomes a totally difficult issue. So the not every patient with diabetes will end up in kidney failure. No. Similarly, it is only the group which have not achieved the target control values for diabetes or blood pressure of less than 140/90, that means 120/80 is the normal blood pressure. So or a blood glucose, fasting blood glucose of around 100 milligrams. Or something like that, your cholesterol less than 200. So these values, when they are not achieved, when you don't keep them in the target levels, then you end up having problems. So it's not every causes like what I said about all this high blood pressure, diabetes. High blood pressure may be a cause of kidney disease or maybe the result of kidney disease. There are 2 ways in it. There is one problem in people mistaking high blood pressure as with what we call as essential hypertension or idiopathic hypertension, because if at any time you can say 15 to 20% of the population can be hypertensive, but that doesn't mean all of them have kidney disease. But in this group, only 5 to 10% who have not able to control their blood pressure, and it lands from mild hypertension, mild blood pressure to severe blood pressure of say 180/110, higher levels. Now, these people land up with kidney failure. So it's not that all these diseases land up ultimately on kidney failure. This is not, but it is true when we have not failed to recognize them and we have failed to put them in the control values that are prescribed.
It may lead to that. So what is the lifespan of kidney disease before its manifestation in someone's body?
It depends upon how fast is your original cause. For example, in diabetes, all over the world, that is #1 cause of advanced kidney failure requiring dialysis, including advanced countries to developing countries. So wherever it is, that is the cause. But it doesn't mean that, for example, last 6 months ago or 1 year ago, your health check has showed a normal blood glucose. This year, you are found to have high blood glucose. That means diagnosing diabetes. That doesn't mean next year your kidney is going to fail. No. There is at least time lag of 15 to 20 years of very slow progression. That is the essence. Even in hypertension, diabetes, this slow progression is the one that makes us lulls and makes us may not recognize in the early stages. So it is only the very alert primary care physician. So you should look for the what is called as target organ damage. Be it kidney, be it heart, be it eyes, be it blood vessels in the legs or peripheral nerves. Wherever it is, one has to be alert to the possibilities of early recognition of kidney disease.
So can this disease that we're talking about, we're going to be looking at some facts and statistics about this disease.
Yes.
But before we get to that, can we control this kidney disease? Can we make sure that maybe, because we have a very high number of people in Kenya and even across the world really struggling because of this disease, can we control it?
Why not? See, if you go by global statistics, at any given time around 10 to 15% of the world population has some form of kidney disease, at some level of kidney disease. Doesn't mean kidney disease doesn't mean what you call severe kidney failure. I'm not talking of that. Disease is different, failure is different. Like you have high blood pressure and diabetes, that doesn't mean you have an organ failure.
Okay.
But the disease will manifest. For example, in kidney disease, the earliest manifestation is a very small leak of protein in urine that is called microproteinuria. Micro, the name itself says micro.
Yeah, which
you have to be very careful and adopt a special test so that you pick up that micro quantity. Now, for this micro quantity to become higher levels called as macro quantity, and then to the extent of kidney failure, you have a time lag of 10 to 15 years or more. So this is quite a good window period that nature has provided so that you can look into the disease process and try to control it with adequate control.
Okay.
So there is no direct medicine to control the kidney disease for lifestyle diseases. For lifestyle diseases, it is controlling the risk factors themselves.
Okay.
But if it is a separate kidney disease, like the immunological, lupus, what we call SLE, common in women all over the world, that is also common, I have seen here. And infections, I have seen HIV very common here with kidney disease. Not only the other manifestations of the HIV disease I have seen here. So I'm talking of chronic, we are limiting ourselves to chronic.
Okay.
Acute, there are so many, even malaria simple can cause. That is acute thing, they are recoverable. You treat them for a couple of weeks, they get well.
Okay.
So one has to understand the difference between an acute disease and a chronic disease. We are always afraid of the chronic disease because it persists and may lead us into dialysis and transplant. Acute disease also may lead us into dialysis, but that is temporary.
We don't take care of ourselves.
Yeah, like malaria is there, like surgery is there, like some kind of dehydration is there. So that will lead also to kidney failure, but that is only for a couple of weeks or at the most a few more weeks. You are on dialysis for a few weeks and then you are off dialysis. This differentiation is important. So we should not get into the mind that somebody is on dialysis for an acute failure doesn't mean that lifelong is going to be on that.
Okay.
No, once the acute phase is over, he is out of the ICU or the post-operative period, he will not require dialysis in life again.
Okay. When I was doing my research, I came through some statistics whereby over 4 million Kenyans suffer from kidney disease, and we have like 14 public centers with the dialysis unit, and we have 48 centers with dialysis units in the country. Speaking about all these things, how do you think what do you think can be done to make sure, because not very many people can afford the dialysis in the private unit, in the private hospitals. What do we do to make sure that there's not a lot of congestions in the hospitals and every patient is not going to have to wait for a very long period of time before getting the dialysis?
As I said just before, at any given time, around 10 to 15% of the world population has some degree of kidney disease. For example, if the Kenyan population, my stats are true, it is around 40 million. As you said, the 4 million is 1/10 of it.
Yes.
So 4 million doesn't mean all of them have advanced kidney disease. In this, advanced kidney disease may be around 2 to 3%. I mean, the totality, if there is 10%, maybe 2 to 3%. 1/3 of them may be having advanced kidney disease. So this is the cost of taking care of advanced kidney disease is really prohibiting, very prohibitive. So to say, if you have to support, for every country, either rich or poor or developed or underdeveloped, it is going to be very taxing on the healthcare system. So the essential focus should be on preventing early recognition of kidney disease.
Okay.
First and primary focus should be on the family physicians, because it is the lifestyle disease that are responsible for increase in the chronic diseases. In the chronic diseases I'm talking. And also, but when it comes to treating only dialysis, so dialysis is only not treatment for the disease. It is a replacement of lost kidney function. If your kidney is not able to work, the machine does it. If the machine and there is a donor available, either a live or a cadaver in some countries, we can replace it with a natural kidney, live kidney.
Okay.
So, but that doesn't treat the original disease, but you still stand a risk of having the disease is coming back, but still you have to always be, the focus should be on early recognition and preventing progression of kidney disease to dialysis and transplantation stage.
Okay, so what would we say is the age bracket, or what can we say are the most people affected by kidney disease in the country and also across the world?
Across the world, if you think, if it is the lifestyle diseases, they start picking up at around 40 and they reach a peak around 60, 65. So that is the peak when you also see the chronic disease stage at a higher stage. So that also they go with the same peak because they are the basic causes.
Okay.
And when it comes to younger, yes, there are children with kidney disease.
That's now would. What about the young? Because we have very little kids who are diagnosed with kidney at a very early age.
So
what could be the cause of that?
Yeah, there are many genetic causes, many congenital causes, many structural defects in the kidneys in children. So the kidney tract itself may be malformed from birth, and if it is failed to recognize by the late adolescence or so, they end up in kidney failure. So that is what is called congenital defects.
Okay.
Structural anomalies, they are birth defects, or else there are certain specific kidney diseases. Like say immunological disorders, and a common example in women is the systemic lupus, what we call lupus nephritis. In simple, that's also common all over the world. Here also has been very common. So it specifically tends to, apart from other organs, the major damage is on the kidney. These patients tend to be younger. So the disease pattern in younger is different when compared to the patient coming to me with a kidney failure at 60 and 50. There I only look at not only kidneys, I look at the heart, I look at the brain, I look at all the other organs. So in younger patients, they tend to have isolated kidney problems usually, and then they tend to do better even after transplantation. Their lifespan around 15-20 years or even more. If everything is fine.
Looking at some of the risk factors of kidney disease, we have obesity, we have smoking, abuse of alcohol. So how now what could you tell, what would you advise to people? Because we know these days people are really neglecting, maybe if it's in terms of whatever we take in our bodies, people are getting to be very neglect on that. What would you say is the right type of lifestyle, the right type of foods that people can now start using to make sure that they don't get to a point whereby they sick, they have to now start going to the hospital to treat kidneys and other diseases? So
this is, see, the basic health measures are same for all the diseases put together, at least most of them. So there is no like separate kidney health, liver health, mental health. See, the general good lifestyle is about timed work, timed rest, and timed workout like exercise or something. So this forms, and diet which is not very atherogenic, or what you call as more of fat in it, not more of calories in it, not more of fat in it. So, and avoiding unnecessary medications. So these three things, they form the core of any general good health practices. When we stick to these things, at least 80 of the other problems can be solved very easily. Okay.
We're going to be taking a very short break in a while and come and talk about dialysis and transplantation. But before we get to that break, how would you say that comparing Kenya to India, whereby you've practiced for a decade, for more than a decade, where is it more cheap for a patient to really be able to manage the kidney disease, either through transplantation or through dialysis? Where is cheap? How do you compare the two countries?
Whenever a certain care is provided in-house, there itself it is cheaper. For example, at least in India, actually it is the reverse. People, when I was young, people were going to US and UK to get their transplants, but later it stopped. It was the reverse. People started coming into India to get transplants. So naturally it is cost for them. So for any other one, so there were two issues. Transplant and at least transplantation is cheaper in India, and the numbers are whopping. So because of the high population, the numbers, we get to see more number of patients. So the expertise is also higher. But for any simple reason, if a patient has to go from Kenya to India or South Africa or somewhere else, it is always costlier. When we try to provide the same care here, the transport and the medications and everything is local here, and at least it cuts down the cost by around
transportation,
half, even transplantation. So that is where you try to save money and provide the care in-house here.
Would you say both the public and private hospitals, or the public and private sectors, are ad hoc sectors that people can depend on and stop just traveling abroad to go and seek
Nowadays,
medical
I don't
care
see need except for
here.
a few advanced tests. The rest of the care can be provided in-house here itself.
Okay.
Only certain technology, that too I think given the modern day of normalization or equalization of cultures all over the world, it makes no difference it is Africa or America as far as I see it. Maybe a little matter of time that you bring the technology down, costs will come down and then you save a lot on expense of treating an end-stage kidney disease.
Okay. We're going to be taking a very short break on Y254 News, but don't forget you can be part of this conversation only by sharing your views and comments to the number 22162. You can also tweet us at Y254 channel, hashtag Y254 News. The topic is kidney disease. We're going to be taking a very short break. We'll be right back.
Y254. Imagine.
You are trouble.
That's my middle name.
These broken bottles on. Stop! Please do it!
I'm gonna whoop all of you.
Please. Dad, stop!
You're fired. Just get the hell out of my house.
Well, it's just a rough patch is all.
Honey, I've seen rough patches. This is a catastrophe.
I'm Dick, and I'm an alcoholic. I want to see my kids. Come on, Betty. God wants us to forgive.
What do you know about God?
What are you doing here, Dad?
You don't want to talk to your old man? There's things I want to say. I believe I will sell a lot of windows. I need some people around me I can trust. Figured I get a chance to get my boys back. You offer me a job? No, sir. I'm offering you a partnership. Love isn't love till you give it away.
Deep in the heart. Y254.
Thank you for staying with us on Y254 News. Tonight we're talking about kidney disease. And now, as we wind up, let's talk about dialysis. At what point, as a doctor, do you advise your patient now to consider dialysis?
So that's what, when I said earlier, when an issue comes that dialysis is, and simply in common man terms, is artificial kidney. Your kidneys are not able to make urine or is not enough cleaning your blood, and all the waste materials, what we call as urea, creatinine, sodium, potassium, acid, phosphorus, all these things are building up in your blood. As I said, we have to always have the differentiation between an acute kidney disease, which is a short-term disease, and a chronic disease. So the fundamental message I want to give to common man, everyone, is whenever your patients or you are told to have a dialysis, particularly for an acute condition like a malaria or infection or a pneumonia or a post-surgical state or even following a delivery, normal delivery, even people require a temporary dialysis support. When the doctor advises that, please don't panic. Just ask him, doc, is it a temporary failure or a permanent failure? So the doctor has his own ways of deciding whether it is a severe damage or recoverable damage or a irreversible damage. That there are medical tests and observation period, and then they decide. So the acute cases, even the patient is on dialysis, that is a kidney support system, so they tend to recover very fast, maybe in a few weeks. But if it is a chronic damage, then the difference is that he will be on dialysis or that artificial cleaning system or the thing for a lifelong process. So this is where and then for this process to start, you have to closely interact with the doctor. It's not like a sudden failure of the kidney and dialysis is a sudden bolt in the blue for the family and the patient. But a chronic thing, there is enough time of at least a few years and months for the patient to prepare himself, so that the doctor and the patient, both of them, will be knowing down the line in a couple of years, I will be requiring dialysis. So that there is enough time for the patient to prepare for the dialysis, for the, like an AV fistula on the hand, which provides the blood supply, the access to the dialysis system, which most of the people neglect, and they'll end up having unnecessary catheters, which is painful, infections, antibiotic. So in the chronic phase, always there is time, if properly followed right from the beginning of the disease. So there is time for them to follow and prepare a vascular access and go for the dialysis, or if there is a donor in the family or in the friends or whatever it is, you can as well go straight away to a transplant.
Okay. Now, speaking of donation of kidneys, does it mean that when someone gets a new kidney, probably from a parent or from a parent relative or donor, does it mean that you're now okay, you never experience kidney failure again, or you're now free from kidney disease? What does that mean?
See, the psychological fact is that kidney, whatever it is, an external organ is an external organ. Even if it's your mother's kidney or a father's kidney, or your own brothers, sisters, or outside organ is an outside organ. So the body rejects or reacts as an outside thing.
Okay.
So we give medicines to suppress that rejection, what is called as reaction or rejection, whatever we call. So to prevent the body from rejecting the
kidney.
transplanted kidney, even if it is from your own kith and kin. Outside kidney, anyway the body is going to reject more forcibly.
Okay.
But if it is from your family, the intensity is less, but still some thing is always there, so that you always stand a chance of rejection from your own body. And some the original disease which has damaged your kidney, it is because we fail to recognize it or we fail to control it.
Okay.
Two things which has resulted in kidney damage. And now the same thing happens now. So these two conditions, like rejection from the body or a recurrence of the original disease, can again lead to kidney failure.
Okay.
But the only difference now is you're on a regular follow-up now.
Okay.
Previously you came only when you were feeling sick, that's all. But now you have, even if you're healthy, every month I'll call you for follow-up.
Going to see the physician.
So you can't escape being misdiagnosed.
Okay. So our last question for tonight: are kidney donors, do they face any risk at all?
See, it is simply a thing. In a live kidney donation, donation or simply, let us simply say removal of a kidney. For even medical other reasons, like there is a tumor in the kidney, we remove the kidney. Leave alone for donation.
Okay.
There is pus in the kidney, or one kidney is not working, so it has to be removed. The fundamental thing is and there are people who are born with only one kidney. So both these people who are born with one kidney and people who have got their kidney removed for medical reasons, disease reasons, both of them, they do well for the rest of their lives.
Okay.
But one has to remember, the other kidney has to be healthy and it should have the capacity to increase. So it's not like in 100% two kidneys, you take away 50%, you are not left with 50.
Okay.
Over time it becomes 70 and 80. It compensates. It compensates, like instead of working 8 hours, you work for 12 hours.
Okay.
That's how it tries to compensate and see that the donor doesn't land up in kidney failure.
Okay. Thank you very much, Dr. Murthy, for sharing all that information that you have shared with our viewers tonight. We're going to have you some other time to make sure that we talk more about this disease. So let us all be very cautious on whatever we put into our bodies. When probably you have this type of disease, make sure that you have checkups with your doctors and make sure that you live a very right lifestyle, avoid smoking, avoid alcohol. Thank you very much for being with us tonight on Y254 News. My name is Patricia Muriuki. Do have yourselves a very good night.